Anyway, so diabetes mellitus is a condition where you're unable to control your blood sugar, either because you're not releasing enough insulin, or that your effector sites, the muscle, the adipose tissue, and the liver, are refractory to the release of insulin and insensitive to its effects, and therefore you don't get this control of blood sugar that you need to maintain homeostasis. You can see from this table that it's a prevalent disease. In the United States in 2015 there were 23.3 million cases that were diagnosed and a further 7.2 million cases undiagnosed. So we're approaching like 10% of the population of the US is afflicted by this condition in one form or another. So that kind of shows you its clinical relevance. There are conditions then that diabetics suffer from that indicate where the pathology of the diseases lie. Diabetics are 2 to 4 times more likely to have heart disease and 2 to 4 times more likely to have strokes. So this is obviously pushes a lot of pressure onto the cardiovascular system, and you're having circulatory issues because of the effects of poor blood glucose regulation. It also can cause blindness and is the leading cause of blindness in people between 20 and 74 years old. And 44% of renal failure cases are found in diabetics. So there's big problems with not being able to control your blood sugar. For your studies, just consider that there are 2 types. If you go into the literature, you'll find that these things are starting to move around a bit, but we're just going to focus on type 1 and type 2. Type 1 is juvenile onset diabetes. It generally occurs in childhood. It's only in sort of 2% of the population, and it usually happens early. And it's characterized by destruction of the beta cells in the pancreas by some autoimmune condition, and as a result you can't release any insulin, and so you have the problems of ketosis happening. I'll go through why that is more prevalent in type 1. You need insulin to treat it because you can't release anywhere, and occasionally you'll have insulin resistance, but generally in type 1 you can't release enough insulin, and that's what causes all the problems. Type 2 then is sort of adult onset. Mainly what characterizes type 2 diabetes is that there's insulin resistance. They can release some insulin, so you don't really get ketosis unless it's rare. And it tends to happen in obese people, at least in 80%. And the general consensus is that poor diet and management of food intake over a chronic period of time then results in type 2 diabetes, because your body stops responding to the insulin that's released. And type 2 is now much more prevalent than type 1. So in type 1 diabetes, which the next slides I'll refer to mainly, you have insulin deficiency, and there are a bunch of metabolic issues that come from that. Now, in the endocrine self-study, we've talked about the sort of 2 sides of the coin. On one side of the coin you've got glucagon, cortisol, epinephrine, growth hormone, that all increase blood sugar concentrations, either by breaking down glycogen or stimulating gluconeogenesis in the liver. And you don't tend to get many diseases where you can't raise your blood glucose concentration, because there's a lot of redundancy there. You've got several hormones that will do it, whereas on the opposite side of things, reducing your blood glucose via hormonal challenges is only done by insulin. And insulin has effects like it inhibits glucagon production, and it puts everything into storage, so it combats the hormones that are trying to raise blood glucose. And then so when you don't have insulin, all these catabolic actions that raise blood glucose and other metabolites go unabated, and there are many factors then that cause pathophysiology. So this is a nice diagram that capitulates all those things, and I'm going to start here on the right. So you have insulin deficiency, and so you've got cortisol being released, and just because you have a tonal amount of cortisol, I'm not assuming there's any stress going on here. You just have a certain amount of cortisol, and normally there's a balance between insulin and cortisol. That means that your protein generally isn't being degraded. But without insulin, cortisol is maximally effective. You get protein degradation, which leads to muscle wasting and weight loss. But also you increase your blood amino acids. And without insulin, which stimulates the uptake of amino acids into the cells, this compounds this, and then you've got glucagon that's not being inhibited by insulin, so you get gluconeogenesis occurring, and then this is going to raise your blood sugar levels, and so you get aggravation of hyperglycemia. And then moving to the left, also you have a decrease in triglyceride synthesis, which is what insulin stimulates, and then you have an increase in lipolysis because you have glucagon and cortisol, and possibly growth hormone and epinephrine flying around. They all stimulate lipolysis, and you get an increase of free fatty acids in the blood as a result. This is an alternative energy source. They go into the mitochondria, you get ketosis happening, and so the levels of ketones in the blood rise because you just have a lot more substrate for ketosis in your blood, and then you just get a large amount of ketones, and ketones are acid, and so you get metabolic acidosis happening. And this can lead to increased ventilation. Your ventilatory drive by your central receptors are through changes in pH. Usually that's due to an increase in carbon dioxide levels, but now it's just due to the pH of the blood, and so you get these increased deep ventilation states. And if you don't regulate this metabolic acidosis, you're going to go into a diabetic coma that can quickly lead to death. And then finally, you have insulin increases glucose uptake into cells by incorporating GLUT4 receptors into the membrane. So you're not going to get that without insulin deficiency. And so you get less glucose uptake into the cells. And what this does is that your muscles, which generally takes up most of the glucose in the blood, is not stimulated to take up anymore, and it kind of feels like it's starving because it's not getting the glucose that's circulating around because there's no incorporation of GLUT4 receptors. So this leads to a kind of intracellular glucose deficiency, and this can result in polyphagia as a result because the muscles are feeling starved of fuel. But also you don't have insulin, and again this doesn't counteract, so you don't have the counteracting effects to glucagon and cortisol, and so you get gluconeogenesis stimulated in the liver by glucagon and cortisol, and this then adds to the hyperglycemia. So we talked about gluconeogenesis from amino acids here. A certain amount of gluconeogenesis comes from glycerol and fats, but also you're going to have glycogenolysis happening, and so your liver becomes a net exporter of glucose under these conditions, and so you have hyperglycemia. This leads to glucosuria because you have so much glucose in the blood, the kidneys are not able to reabsorb it. This leads to osmotic diuresis because now your urine has an osmotic component in it. It has glucose in it, and that draws more water into the urine, and so you end up going to the bathroom all the time through osmotic diuresis. This leads to dehydration, and so you're thirsty all the time. but also results in cellular shrinkage because fluid's being pulled in out of the intracellular compartment, and this can lead to nervous system malfunction and death. And also the dehydration reduces your blood volume, and then you have peripheral circulatory failure that can cause problems with the kidney as well, and all these can lead to death. So you can see in the absence of insulin, the catabolic hormones have a field day, and all these effects happen then because you just don't have this this break in it due to insulin. Because insulin's the big storage hormone, it puts everything away, and if you don't have that signal to put everything away, everything just stays and overwhelms the system. I think it's good to point out here that the reason that you get metabolic acidosis is just the ketones don't get used. You've got lots of glucose in the blood, you've got lots of ketones in the blood. Glucose is going to be used first, and these just hang around and cause this metabolic acidosis. So this graph is just an example of a glucose tolerance test. You should just be familiar with how people test for glucose tolerance, and so people will be given a bolus of glucose, and then they look at how the serum concentration of glucose changes over time. And so here we have patient 1 with the circles. You give him oral glucose or her oral glucose, and it increases over the next sort of hour, and then is kind of regulated and comes back down to normal within a couple of hours. Patient 2 in the upper triangles, they have a normal resting glucose, but when you give them glucose then and monitor them, their glucose levels stay high and persist in being higher. This is traditional what you would see in sort of people with metabolic syndrome or early type 2 diabetes. They're able to control their blood glucose levels reasonably well, but still outside of normal ranges, and that means that they're kind of falling towards diabetic pathophysiology. And then patient 3, you can see it has poor blood glucose even in the fasting state. You give him glucose, and the plasma glucose concentrations keeps increasing, and they have very, very poor control of glucose as a result. And this is because if you don't have insulin and it's not effective, then these things don't happen. And this graph just summarizes what you can expect to see when you give someone insulin. You give someone insulin, their plasma concentration of insulin rise, and as a result glucagon is inhibited, glucose is removed from the circulation, free fatty acids are removed from the circulation, ketones are all removed from the circulation, and you excrete less nitrogen because more amino acids are being used for protein synthesis and things like this. And so without insulin, none of these changes are going to happen. Like, things are just going to build up unless they get used. So in type 1 diabetics, they can't release insulin, and so they have to have preparations of insulin to control their blood glucose. And there are many different types of preparations, and they differ then by their time to onset, how quickly they will react, how long they will cause an effect for, and how long to the peak effect, and then how long they will be effective for. I'm not going to go through these individually, you can read them in your own time, but there are many different preparations. So the chronic complications of diabetes generally falls down to the inability to control your blood glucose levels, and these have many kind of effects that result in these sort of pathophysiologies. Now, I talked at the start of heart disease and stroke being a big thing, and so these are due to macrovascular disease, where your blood vessels become less compliant. It increases blood pressure, and it can result in coronary heart disease or cerebrovascular disease or peripheral vascular diseases. And this is due to high blood pressure, and also if you don't have insulin, you're increasing the amount of circulating fatty acids and triglycerides, and these can all result in the increased likelihood of atherosclerotic plaques. There's also microvascular diseases. This is classically involved in the small vessels found in the retina or in the kidneys, and these undergo kind of the same conditions. They lose compliance of these small capillaries, and in the eye they're likely to rupture. In the kidney you have poor filtration, and the small membranes can rupture and cause problems, leading to kidney failure and death. And then there are also neuropathic diseases coming from this increase in blood glucose that just generally makes the nerves hyperactive, lots of pain, resulting from this poor glucose tolerance. And so this slide sort of shows some of the effects that can occur through poor blood glucose regulation. So we start here on the left with glucose, and one of the ways that it causes issues is what's known as the polyol pathway, whereas glucose comes into cells. Now, I talked about at the start that insulin affects, the insulin affects the liver, it affects the adipose tissue, and it affects the muscle by incorporating GLUT4 transporters. But virtually all cells have some type of GLUT transporter, and with the concentration gradient being what it is in a diabetic patient with poor control of their blood glucose, you get glucose then flowing into these insulin-independent cells, if you like, and overwhelming the metabolism of them. And one of the places that it causes issues, or thought to cause issues, is through the polyol pathway. And what the polyol pathway does is it takes glucose and turns it into fructose via sorbitol. Sorbitol is not really used for anything, and this pathway gets overwhelmed, and so you get a large buildup of sorbitol, and that can't get out of the cell, and it creates an osmotic pressure, and it's not really metabolized very fast, and so these cells sort of swell and cause osmotic damage that can then cause ruptures in the retina of the eye. With the amount of glucose that's circulating around the blood, you get excessive glycosylations, and these you then end up with what are called age proteins, advanced glycose end product. One that you should be familiar with is HA1C, which is the glycosylation of hemoglobin, and this is just generally as a marker. You can monitor someone's sort of 3-month blood glucose control by looking at how glycosylated their HbA1c measurement is. But also this glycosylation can crystallize alpha-crystalline in the lens protein, and this can enhance cataract formation. You also have UDPN acetylglucosamine. This is increased with high glucose levels, and this can make the vitreous humor of the eye more viscous and causing problems with sight. And then you have UTP galactose that then causes excessive glycosylation of basement membrane proteins, and this can result then in defective filtration and transport across these membranes, causing the pathophysiology. So you can sort of summarize the effects of hyperglycemia and its chronic effects by this chart. and this is a sort of a unifying hypothesis of diabetic complications. So with high intracellular glucose, you get increased advanced glycosylation end products, and that then results in abnormal protein functions and abnormal cell functions that then lead to the complications that we've talked about. Increased glucose, as I said, results in increased sorbitol production because of the polyol pathway, and that leads to cell dysfunction through osmotic stress and stuff like that. You also get excessive activation of diacylglycerol pathway, and then this results in an overactivation of PKC and altered gene expression, which then can also contribute to the pathology of diabetes. And then increase in fructose 6-phosphate, end product of the polyol pathway, can also enhance the glycosylation of proteins that leads to abnormal cell function, and then all the pathologies from that you get in diabetes come from generally one of these 4 mechanisms. So we've just talked about what happens with too much glucose, and these are generally chronic issues that happen. Hypoglycemia is much more critical because your CNS will shut down within several minutes if your blood glucose bottoms out. And so when you have hypoglycemia, it's a stressor, so you're going to get sympathetic activation, catecholamine release, and that's going to result in sweating and shakiness, anxiety, all the things that come from too much epinephrine in your body. And then, if your hypoglycemia is very extreme, then you'll have confusion, irritability, weakness, and convulsions and coma, because you just don't have enough energy to sort of function and maintain your normal circumstances. And so talked mainly about diabetes 1. The last few slides are focusing. We'll move over to diabetes 2 for the last couple of slides here, and just to reiterate what it is, this is sort of adult onset, comes about generally through poor diet, although that's not all of it. So there are obviously things that we don't quite understand why people who are not obese become insulin resistant. But like I say, you don't tend to get ketosis, and so I've talked through what happens in ketosis. So the reason that type 2 diabetics generally don't ketosis is because they still release enough insulin to prevent metabolic acidosis, but generally they don't release enough to control their blood sugar. And so these are 2 examples of the pathways that can affect type 2 diabetics. You have a beta cell problem, either through mitochondrial dysfunction, and your fatty acid metabolism is abnormal, you don't get enough ATP, and so your potassium channels remain open, you have membrane hyperpolarization, and so your calcium channels don't open, and as a result you don't get insulin release, or the insulin that is released is not sufficient enough to control your blood sugar. But you can also have the target cells are insulin resistant. You take in calories, and this is going to reduce your mitochondrial fatty acid oxidation, your intracellular fatty acid metabolites build up, and these sort of inhibit the insulin-induced glucose transport. So for some reason, and people are pointing towards disordered fatty acid oxidation, that the cells just don't respond to the insulin. You don't get incorporation of enough GLUT4 receptors to lower the blood glucose fast enough to prevent pathophysiology. So this last slide shows you treatment methods for people who are suffering with diabetes mellitus 2. You have alpha glucosidase inhibitors. These are inhibitors of carbohydrate digestion in the GI tract, and so you're by preventing the breakdown of complex carbohydrates and starches, polysaccharides and the like, you're going to decrease your carbohydrate intake into the GI tract, and this is going to reduce the overall level of blood glucose by preventing it getting too high through absorption. Then you have two compound types that are similar in their modes of actions. You have biguanidines and thiazolidinediones, and these both decrease the hepatic glucose output by reducing gluconeogenesis. They also increase insulin sensitivity in the effector sites, and these both happen through sort of nuclear receptors in the cells, although their mechanisms for action aren't fully understood. Then you have, but both of them will decrease glucose output from the liver and increase glucose sensitivity, and as a result then you reduce hypoglycemia. And then you have sulfonylureas and meglitinides, and both of these inhibit the potassium channel in insulin releasing beta cells of the pancreas, and so supplementing these into DM2 patients' diet, you enhance the amount of insulin that's being released, and that will then contribute to the reduction in hypoglycemia.